Hello, party people! It's Monday, Monday, and I am Dr. Dan Lieberman, the medical director here at Phoenix Spine and Joint. I'm excited to bring you today's updates on musculoskeletal news. Some really interesting and cool stuff going on, and I honestly very excited to show you what's happening and what to expect. Well, the first piece of news, we're going to talk about a new study on anterior cruciate ligament reconstruction. And in particular, the study is from the American College of Sports Medicine. They're having their annual meeting, and so lots of kind of cool and interesting information is being presented. Most of us today are too young to remember, but originally the anterior cruciate ligament was not often reconstructed, it was more often repaired. And that means they just, when you tore it, they just sewed it back together. And unfortunately, as you might expect, given that ligaments have very poor blood supply and limited capacity for healing, it often didn't heal real well. And people went out there and did their thing, athletes and what have you, and they often tore it again. And gradually, surgeons started something really different than repair. They started reconstruction. And it's been so long that maybe it's worth taking a moment to look at what reconstruction actually is and go through it before we dive in to this study and look at repair versus reconstruction. So let's take a look at this video. And I am going to make it full screen so you can really see it. So this is the knee, and this is the thigh bone, and here are the leg bones. And the thigh bone rests on the two menisci, one on the inside of the knee, the other on the outside of the knee. And the anterior cruciate ligament was this guy who went across the front. And if we back this video up to the very beginning and then replay it, you're going to see this is the anterior cruciate ligament. I'm sorry, this is the patellofemoral tendon. The anterior cruciate ligament is behind us, but in this case it's going to be torn. So this is the patella, the kneecap, and this is the patellofemoral tendon, the connection between the kneecap and there. And what they're trying to show us here is this looks to me like a kind of a candy cigarette, but it's not. It's the tendon, a little piece of the tendon that has some kneecap bone here and some leg bone here. So it's a graft that they're going to use in just a second. Watch what happens. Okay, so here's the anterior cruciate ligament, and it's torn. That's what those two edges missing are. And you can see this is the thigh bone, and again, these are the leg bones. So the thigh bone with this ligament torn could shift compared to the leg bone, and that leads to instability. We're under the patellofemoral, we're under the ligament, the tendon that connects the kneecap to the thigh bone, to the leg bone. So we're here. They've taken out the broken elements. Now they're putting in a graft, so that made room for the graft. And then here's the graft they took out of that patellofemoral tendon. And then they're going to lock it in position and then leave it be. Now, some interesting things about that as we look at it again. The ACL tear, we could have just sewed those two edges back together. Instead of taking them out, we could have repaired them. But instead, we're doing the reconstruction. And because this is bone and this is bone, those bony ends of the graft are going to, once they're in there, are going to heal and grow back into the other bone. And that is the long-term thing, which is going to hold them in position. Pretty cool, right? I mean, really cool.
not buy solar panels if you live in
hold
one
on.
of these 11 states of America. It's the worst decision you could make for your home. Did you know?
Sorry, got carried away. Yeah, I mean, I think it's actually super interesting and super cool. But beginning about 30 years ago, almost all orthopedic surgeons started to see that, hey, the repairs break so much, and we don't want people coming back and being all grumpy pants, hey, it didn't work, and it didn't. And so they pretty much as a group shifted from repair into reconstruction. And now, guess what is happening? Here comes a study from the new meeting. Researchers say people who have knee repair surgery tend to have better outcomes than those who undergo knee reconstruction surgery. And it's actually the anterior cruciate ligament, not the knee in general. What? That's exactly the opposite of what we just said, right? I mean, we just said that it's the opposite. So what in the heck is going on here? Mobs are forming outside. People are questioning our judgment. It's really weird. Well, let's look at the study. So Tom Melhuzem knows the difference. This is a guy who had both surgeries. And Tom Melhuzem, when he had a anterior cruciate ligament reconstruction, took him 11 months to get back to play. I think he was a soccer player. Whereas when he had a repair, he got back in, just 5 months. Ooh, well, who would choose 11 months if you could choose 5, right? Nobody. So they're talking about this research in the 2022 American Orthopedic Society of Sports Medicine. And, just as our usual viewers know, there are specialists who do bone work, like orthopedic surgeons. These are people who do 5 to 6 years of additional training after medical school and a year of surgical internship to learn how to become specialists in fractures and knee surgery and hip surgery and all kinds of good surgeries. But then there's another group who goes on and does a 1 to 2 year of additional training in arthroscopic surgery of the shoulder and the knee. And for historical purposes, these surgeons are called orthopedic sports medicine doctors, orthopedic sports medicine, and they are some amazing docs. Anyway, they looked at two groups in this study. They looked at people who had this ACL repair, and then another group who had the reconstruction. They compared them age, gender, body mass index, that's your height divided by your weight, basically, how big you are, the time between injury and surgery. I'm sorry, that's your weight divided by your height, and BMI. It's actually a little more complicated than that, but knee laxity parameters, the presence of meniscal lesions, preoperative activity level, and sports participation. So very, very interesting set of parameters to look at. And 6 months after the operation, they used some isokinetic testing. So they had people do some exercises and they looked to see who was stronger, who returned to sports faster, who had a better outcome. And what they found was the people who had the repair had the better outcome. Interesting. Very interesting, right? Because that's not what we would have predicted. For 30 years, orthopedic surgeons have all, as a group, shifted toward reconstruction over repair. So were they wrong? It's happened before, but it's frankly very uncommon. But was the entire field wrong? Well, no. This is a classic example of something in medicine that we call selection bias. So this is a study of people who had repair and people who had reconstruction. Who gets repair? First of all, almost no one. Almost everybody gets reconstruction. So the only people who get repair are going to be the ones with the easiest to repair, close edges, most fit, the ones the surgeons say, I almost never do this, but you're such an amazing candidate. Let's repair it. So you're not comparing apples to oranges. you're not comparing apples to apples. You're comparing the very best, shiniest, most delicious apples in the world to turnips, right? It's not a study. It's not. And so how do you know when you look at studies, how do you know that they actually did a fair comparison? Randomized controlled trial. Randomized means we didn't pick all the winners. We didn't pick everybody who looked great and put them in one group, and everybody who looked like, maybe they're not going to do well, and put them in a group. We randomized. When you came in, we said repair versus reconstruction. That's not what happened here. Here they looked at it through the rearview mirror, the retrospectoscope, so to speak. They said, hey, let's look at who had repair and let's look at who had reconstruction. And to be honest, this kind of data is such crap that there's no point in even reading studies like this. It is kind of interesting. Okay, maybe there's something out there, maybe for future look, but I don't think any orthopedic surgeon is going to change what they're doing based on this. And in fact, that's kind of what the word was from the meeting. That doesn't mean ACL repair is easy, this Dr. Trinacosta said. This is apparent if looking at past literature and research on this subject. It fell out of favor decades ago as a treatment technique because of significantly higher re-rupture rates. So Dr. Trinacosta is pointing out, we did this in the past. The rate of re-rupture was so high, I'm not going back there. Dr. Alan Bayer, another orthopedic surgeon from the Hoag Clinic in Southern California, said the decision to reconstruct or repair isn't simple. This study may be a good start, but I'm not going to let one study dictate how I approach ACL repair or reconstruction over the last 40 years of practice. Bravo. Doctors don't, one study doesn't come out and we don't bet the farm on it. We look at the pyramid of evidence and look at not only what kind of trial was it? Was it a randomized control trial? Was it a trial with a crap ton of selection bias like this one? Or after that, combine the trials into a meta-analysis, a systematic review, and then we can gradually come up with the right answer. Dr. Kevin Stone, an orthopedic surgeon with the Stone Clinic in San Francisco, patients have a choice. Well, that's true. That's true. However, very few ligaments are ideal for repair alone. They're all basically saying this is bogus. So what are you going to do? When you're out there playing basketball and you hurt your knee, or you're just getting out of the car and you hurt your knee, you can't walk, you have an x-ray, normal. Doc, I can't walk. They get an MRI, complete tear of the ACL. You have to, you go see an orthopedic surgeon, Dr. Studley, and they say to you, hey, you've got a choice. You can have a repair or a reconstruction. I think, if it's me, if they're offering me, first I would say, the normal treatment here is reconstruction, doc. I'm a Phoenix Spine and Joint member. I've read that repeatedly. How come you think I might be a candidate for a repair? And if the doctor says, look, I hardly ever do repair, but yours is just perfectly aligned. Look on your MRI. You're young and healthy. You're the most beautiful knee I've ever seen in my life. You should be a knee model. So if all, they convince you that for some reason you actually are a candidate for either one, then it kind of comes down to this. You got a much higher risk of failing if you have repair, but you're rolling the dice on a quicker recovery probably. So you have to decide, is it really going to bother me if I get out there and my repair tears? Is that going to break my heart, make me feel depressed, and make me start over? Or would I be like, all right, I took my chances. Now I'm going to just go get it reconstructed. Or are you a one and done? I want to have one surgery, doc. I want to be done with this. I'm never coming back. I want to return to sport. I don't care if I could have done it in 5 months. I want to go with the sure thing over 11 months. That's kind of the decision that you have to make. I would never get the repair. I never. I think there's a really, really low chance that that's going to work. And overall, it would just be crazy, crazy, crazy thing to do. All right, here's a kind of a crappy article, but interesting nonetheless. ET Health World, never heard of it, but this came out today in my feed. Advantages of robotic knee replacement surgery. That's something I'm interested in. because robotic knee replacement, in my mind, is one of the great developments in raising the bar for knee replacement. Knee replacement is probably not something we talk about as much as we should, but when you look at patient satisfaction scores for hip replacement, it's really high, 92%. But for knee replacement, it's not that high. Total knee replacement, total patient satisfaction is more like 74%. That's actually pretty crappy for such a significant surgery, but it's a great surgery, right? Well, we're hoping that when you look at the causes of failure, we can reduce them with the robot. And the final verdict is still out on that. But let's see what this guy says are the advantages. Robotic knee replacements, just like traditional, that's true. The surgeon removes the damaged tissue, yes. The difference between is the robot. Well, robotic knee replacement. All right, so far this is not exactly groundbreaking journalism here. A large number of people suffer, they get robotic knee replacement. We live when a myriad of medical advancements are out there. Osteoarthritis, yeah. 90+% of people in the Australian registry who are having knee replacement are having it due to osteoarthritis. That's why you get a knee replacement. Robotic is just like traditional. The surgeon prepares the joint, but there are several benefits. Okay, we're getting there. The surgery is precise, accurate, and restricted as exact incision and angles can be targeted. Yes. So during robotic knee replacement surgery, your orthopedic surgeon is going to have tools like a drill that are outfitted with reflectors that can be seen by GPS cameras. Those are going to restrict where he can drill and aid him in getting a very, very precise imprint for the implants to go into. In fact, when you compare human ability, like human carpentry, like how accurately can we drill this, with the robotic stuff is 4 times, 400% better. So, I mean, not surprising, right? Even the very best surgeons are not going to be as steady or as accurate as a robot. And for my money, I love the way they do it now, which is I don't want the robot going nuts on my, I want the robot and the surgeon. I want the surgeon holding the thing, but then the robot making them more accurate and better. So I really like that. I like that. I think for me, I like the way they're doing it now. CT scans are avoided by using an advanced computer program to collect anatomic alignment information about the knee. No, I mean, the most common robot in use in the United States is definitely the Mako from Stryker, and the Mako requires a CT scan to make a model of the knee ahead of time. There are robots from other manufacturers, like Smith & Nephew now has a pretty cool robot, and I think there's 1 or 2 others coming out. And Smith & Nephew's robot does not require a CT scan, but who cares? Get a CT scan. Is it radiation? Yeah, but I mean, not much. Is the sun radiation? Yeah, but not much. I don't think it's an issue. If you're super, oh my God, I'm wearing tinfoil in my hat because I don't want radiation, then yeah. But if you're kind of like usual, hey, nothing ventured, nothing lost, I got to get out of my house or I'll never live, then I would go with the one your surgeon's comfortable with, which is probably the Mako. It's interesting, in my old surgery centers, I had both the Smith & Nephew and the Mako robot, and the vast majority of surgeons preferred the Mako robot, but one of the very best surgeons preferred the Smith & Nephew. So what does it mean? I don't know. I think you pick, as long as they're using robotic assistance, not a lot of evidence that one is particularly better than the other. Okay, so wrong about the CT, but right. The surgery will aid in faster recovery, enhanced dexterity, minimum surgical complications, patient satisfaction, and less surgical trauma. A lot of that is not proven, but hopefully for people who are hoping the robots can make us better, hopefully true. But there's definitely enhanced dexterity. Patient satisfaction, the verdict on that, as my understanding of this literature is verdict's still out on that. Less surgical trauma, maybe, not for sure, but maybe depending on how it's done. The procedure has revolutionized knee replacement due to the increased safety and accuracy. It's with the help of a computer to assure accurate results and no chances of error or scarring. There's definitely going to be a scar. I mean, I don't care how good your orthopedic surgeon is, there's going to be a scar or you didn't get the surgery. So that's not true. There are fewer chances of infection. That's been proven to some degree. Rehabilitation times tend to be shorter. That's been proven. And there's also a lower risk of post-op complications, also proven, which is kind of the same as the previous two. One can walk freely and do all activities just like before. Well, very interesting, all true. They did not mention what I personally think is probably the biggest advantage of the robotic system, and that is the implant selection. What they, when they take that CT scan, the computer makes a three-dimensional reconstruction of your knee. Then they put these reflectors on your leg, your thigh and your leg in the surgery, and they bend your knee. And then the computer looks at makes a model of how your knee joint is moving to optimize your range of motion. There's different components to an artificial knee. There's the thigh part and the leg part, and the two have to come together. Slight differences in size and angles and what have you can lead to thousands, if not hundreds of thousands of different combinations of components. And I mean, that's just more than one person can do. That's a great job for a computer. The computer is actually going to correct the angle, make it perfect, and optimize the range of motion by selecting the implants that give you the best outcome. Ooh, I mean, that sounds really, really good to me. In my mind, that's exactly what I want.
Yes!
So, I would definitely, if I were having this done myself or somebody I love, like my wife or one of my family members. In fact, my brother is having surgery, a knee replacement this summer, and if he told me he was going to a doctor, he's going to an amazing doc. But if he was going to a doctor who didn't use a robot, I would say skip on that, bozo. You need to go to somebody who does this the right way, which in my mind right now is with a robot. So very exciting. All right, from robots to weed, let's talk about cannabis for the pain management after rotator cuff surgery. Yet another very, very interesting sort of a thing, and I was hoping to make this bigger, but I don't see it. I'll just go through it. Cannabidiol, so that's CBD. Remember, this looks like marijuana, but it's not. This is CBD is typically from hemp, which is a non-psychoactive. It does not have THC. It's a non-psychoactive medicinal plant, which is totally legal now in the United States. This was looking at post-operative pain following arthroscopic rotator cuff repair. Oh, interesting. So they gave people CBD, Dr. Aliyah and colleagues, in a placebo-controlled, that means one group got the CBD and the other group got sugar pills or something, randomized, okay, so no selection bias. They said, you are having surgery, you flip a coin, you're in the treatment, you're in the CBD group. And they didn't tell you. Then you flip a coin, you're in the other group. You don't know which group you're in. And then they're going to ask you about your pain of people having rotator cuff repair. 80 patients, okay, that's a decent number, not a huge number, right? 80 million would be good, or 80,000 if this was like a drug study for heart disease, but 80 for a surgical study, it's a good number. 18 to 75 years old. They got 25 milligrams of CBD 3 times a day if they weighed less than 176 pounds, and 50 milligrams of CBD if they weighed more than 176 pounds. Well, I'd get the 50 for sure. Currently, CBD is FDA approved for seizures, blah, 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 memory, cognition. Certainly not for pain, but what they're saying is we're going to do a test. And how are we going to know if it works? We're going to check your visual analog score. That's where we ask you on a scale of 1 to 10, how much did it hurt? Or have you mark, and here's 0, here's 10. You mark where it hurt. They're also going to look at how much opiates you took. So you had the surgery, how much Percocet or Percocet, Vicodin, Oxycontin, oxycodone. Satisfaction, with pain control. So was your pain under control, yes or no? And then no pain and worse pain. They also look at liver function tests, make sure you didn't box your liver taking this thing. Okay, on day 1, the VAS pain score, that's how people indicated their pain, was significantly lower in those receiving CBD, which also meets VAS for shoulder arthroscopy. Okay, so it worked. Patient satisfaction with pain control tends towards significance favoring the CBD group. So patient satisfaction is about the same, but it did make them feel better. No significant difference in opioid consumption. So people took the hard stuff or they didn't, which was actually relatively small in both groups. Notable, people receiving 50 milligrams of CBD had lower pain scores than those who had 25. Okay, that's good to know. That's really good to know. Well, that's interesting because a couple of findings there. First of all, they were more comfortable. Not a ton, but definitely more. Didn't make a huge difference in their opiate use, which would have been even more dramatic to say, okay, if you took CBD, you didn't even need that crappy opiate, which is addictive and can ruin your life and kill you. But it didn't do that, but it was still pretty good. So what to do? Well, I mean, this is a no-brainer, right? This stuff comes from a plant that's legal. It can reduce, they didn't talk about it, but it might be able to reduce the not only pain, but anxiety and other things. So to me, it's a no-brainer. Well, why not just, why'd they take it as a pill? Why not just put it on as a cream? 2 reasons. First, creams don't actually go in where you put them. My elbow hurts, so I put the cream on my elbow. Good for you. But your mom, remember when she kissed your elbow and it felt better? She also kissed your cheek and it felt better. And none of us have our cheek in our elbow. So it's, when you put something on the skin, it just gets absorbed into the skin, circulates and goes where it's going. It's not actually better, where you put it, the cream. So why not just use a tablet? Second reason, after surgery, you can't put a cream on a fresh wound, right? There's an incision there. You get probably cause some kind of an infection. So that's why, and I'm glad that they did it that way. Well, that's it for Monday. We covered some interesting ground. Thank you so much for being with me. It was a pleasure to see you. Remember, please put in the comments if you have any brilliant ideas about this, like, oh, we never want to see this again, and this is really not very good, and I don't ever want to come back here. Or, hey, thanks so much. This gave me useful information, which really helped me understand what I should do. Either way, let us know. I would love to see you here again, and I hope you have a great week. I'll try to get these going as we get more information coming in, and really look forward to seeing you again soon. For Best Practice, I'm Dr. Dan Lieberman.